mostly, babies dictate where, when, and how to be born. But sometimes it needs the intervention of a doctor to say, the baby has to be born now and via this method. Today at Caesarean Medical Center, we are privileged to have the resident doctor, Dr. Murigi. Hi.
Hello.
Good to have you in our show.
Thank you for having me on the show. I enjoy it very much.
Thank you very much. We are here because we want us to discuss about emergency cesarean section. Because this is an area where it's the doctor who decides that the baby has to come out now and by this, via this route.
Yes.
But before this, I see you have very many machines over here.
Yeah.
So could you please take us around and tell us what they are for?
Okay. I can start from the back. We have the gas cylinders, which are used to normally given to the patient and are used in keeping them asleep during the procedure. They're connected to this tower, especially through this mask. This mask is what is used to give the patient's gas.
This is the one that goes to the patient?
Yes, to the patient.
Okay.
And then it is controlled here at this tower by the anesthetist during the procedure. When he works it, he or she works it accordingly. Yes, until the procedure is completed, and then the patient is moved to another room. Yes.
And what about this metal?
This metal is called a drip stand. We normally attach, there's a bottle of water. It can either be Ringer's lactate, normal saline, depending on what the patient requires. And it is given as an infusion through the IV line that you normally see in a patient's arm most of the time.
That's very good.
Yes.
Now, as we discuss about cesarean section, they are done here in your theater. Could you please tell us about how many people are involved in the actual operation? Or rather, how many people make the team?
At any given time, I would say between 4 to 6 people, depending on the time of day. During the day, we have more people, so about 6, but in the evenings or at night, about 4 people in the team.
Okay, could you please say who these people are?
Oh, the people in the team, we can start at the head of the table. That is the anesthetist, who we mentioned controls the tower. There's this side, the surgeon's side of the table. On this other side is the assistant surgeon or scrub nurse. And at the foot of the bed is normally the person who receives the baby during the procedure.
That's the midwife?
The midwife. No.
Okay.
Yes.
So a minimum of 4 people. But the many the better.
Yes.
In case of an emergency.
Yes.
Thank you very much. Now I want us to discuss emergency cesarean section.
Okay.
When we talk about emergency, then there must be one that is not an emergency.
Yes.
So please tell us.
We'll start with the emergency is an urgent, it is immediately required. So it is a cesarean section, meaning it is an operation done to surgically deliver the baby from the mother's womb. It being an emergency means that it is not planned for. It is an immediate occurrence that has necessitated the need for that operation.
So the mother was coming to hospital to give birth?
Yes.
She didn't know she would go to theater?
Until she arrived and was examined in hospital.
And it's not her decision? No.
At that point, no.
Okay.
Yes.
Tell us about it.
What happens with an emergency cesarean section? One reviews the patient, you take your history, you examine the patient, and now depending on what factors or what we call indicators or indications, for the operation, we now inform the patient about the decision for the emergency cesarean section. So the factors we look at, we can divide them broadly into 2. The baby or fetal factors or indications, and the maternal indications. When you look at the fetal, you've examined the mother, you've noticed that the baby's heart rate is not well maintained. So it means something is wrong in the mother.
Because you can be able to pick the baby's heart rate before it's born?
Yes, we can.
Okay.
Yes.
That's great.
That we do by, there's an instrument we call a fetoscope. You're able to listen to the baby's heart as part of the examination. And if you feel that it is not going accordingly, that is one of the indicators for emergency cesarean section. That is what we call one of the fetal factors. Another one will be how the baby presents. By presentation, we mean the ideal situation is head down. But if a baby comes with a different position, for example, bottom down, we think of the indication again for emergency cesarean section.
Okay, when you say head down, means if this baby was to be born normally, not via cesarean section, because cesarean section is also a normal delivery. If it was not cesarean section, the head would be born first.
Yes.
Okay.
But now in this case, as you've mentioned, that is now the normal position for the baby. So if it is different from that, that is another indication for emergency cesarean section if it is picked up at the time the mother presents to hospital.
Okay.
in labor.
What else about the baby?
The baby, we also look at other factors. This is something most people have seen. They call it the umbilical cord, what forms the umbilicus or belly button, how we attach to the mother. We have a cord which is a combination of vessels running through it, and if it comes out fast before the baby starts the journey downwards, that is another indication for emergency cesarean section.
Okay.
Yes.
What about maybe issues with the placenta? Would a placenta dictate how the baby will be born?
Yes. Now again, that will be most likely, if it dictates that, that now pushes it towards an elective cesarean section, which is different from emergency in that elective is planned for.
Okay.
It is something that has been seen during the mother's follow-up in clinic, and the decision has been made to plan the cesarean section ahead of time.
So issues of placenta, if they are discovered earlier, it would be prepared as an elective cesarean section.
Yes,
You don't have to wait for it to be an emergency.
No, we don't.
Okay.
Yes.
But still, as we talk about the baby, what about the size of the baby? Can it dictate how the baby will be born?
Yes. Because an example would be, let's say a mother has given birth to, we call them normal weight babies, maybe the previous 2 or 3 deliveries, and then the current delivery she has, the baby is noted to be a larger baby than her previous pregnancies. If the weight is noted, deemed to be too big, then that is an indication for cesarean section. Yes. So that if it is determined that at the time of review, the baby is too big, then it necessitates an emergency cesarean section if she has begun labor. Yes.
What about some malformations? Can a baby have malformations that will dictate for a cesarean section?
Yes, we would. The commonest we've seen here or generally in the country would be hydrocephalus, which is how the baby has a large head, which is fluid filled, and that baby cannot come out the normal way.
It has to be cesarean section?
It has to be cesarean section.
Okay.
Yes.
This is interesting. So the babies dictate how they'll be born.
Yes,
so it was true.
It is true.
Thank you very much. I think we need to go for a break. Okay. When we come back, we'll go to the mother and see how the mother's factors dictate cesarean section.
Yes.
Keep with us. Welcome back to our discussion at Caesarean Medical Center with Dr. Murigi. We are discussing emergency cesarean section. Doctor, we've talked about the fetal factors that determine or rather dictate for a cesarean section. Please tell us about the maternal factors.
So the maternal factors that determine or dictate the necessity for emergency cesarean section, the first cause that comes to mind is bleeding, or what we call APH or antepartum hemorrhage. This is bleeding that occurs after 20 weeks of gestation up to before labor starts for the mother. So at this point, the mother presents with bleeding, and you have to determine if the mother is safe enough to go for the emergency cesarean section. So at that point, we determine and we make the decision and then inform the mother regarding that.
No, it's cesarean section secondary to the bleeding.
Yes, it is.
Okay. Any other thing?
Another factor would be something we call CPD, or cephalopelvic disproportion. This is whereby the baby's head is larger than the mother's passageway in terms of the birth canal because of issues with the bone formation, her bony pelvis. So the passageway is affected and the baby cannot come down the normal way.
Now, when you talk about disproportion, it means there are two things that are not cooperating, that are not proportional.
Yes.
So in this case, it's the baby's head and the mother's birth canal.
Yes.
The pelvis.
Yes.
Oh, that's big. So big names, simple explanations.
Yes.
Okay, another thing.
So the third factor would be something we call poor progress of labor, which comes about because the uterine contractions, or the uterus where the baby is contained, the contractions are not well coordinated to push the baby out of the birth canal. And if that duration exceeds a certain amount of time, that necessitates the need for emergency cesarean section for that patient.
So when you say exceeds the time, that means there is the time, like the appropriate or rather the known time when labor should be done with. Like the mother should not exceed this time with pains.
Yes. We normally have there's a tool we use in maternal care we call a patograph, which is a graph normally used to monitor the mother and the baby during labor. There are certain aspects of that a tool we are calling the pathograph, where if she crosses a certain threshold, then we require the emergency cesarean section. Normally, for women who are having their first baby, we normally estimate a rate of about 1.2 centimeters per hour of dilatation of the cervix or the passageway for the baby. For ladies who have had one or more children, we estimate it to be 1.5 centimeters per hour.
Okay.
So given with that, depending on her starting point, and if she exceeds now that duration of time, we now need the emergency cesarean section.
Okay.
Yes.
Is it possible for a mother to go through labor and get to fully dilatation of the cervix and then the baby just refuses to come?
Yes, it is very possible.
After all that pain?
After all that pain. It is unfortunate, but yes, it does happen. So what normally happens that we may call a delayed second stage. That is, second stage is now the point from full cervical dilatation to the time the baby should have come out. If a certain duration of time again has passed, 2 hours for women who are having the baby for the first time, and 1 hour for women who have had babies before. If the baby is not delivered within that window of time, then it necessitates again the need for emergency cesarean section.
Let me just ask, there are people who are unfortunately go through some problems. For example, maybe a person, now it's not a patient because it's already treated and healed, had something like cancer of the cervix. And they are pregnant now and they've come to deliver. Is it possible for them to deliver normally, or they would go for a cesarean section?
I would say it's unlikely for them to deliver normally because when we mention the cancer of the cervix, it means the cervix has been affected. Okay. And because it is a passageway for the child, that means it will not function as expected, it will not behave as expected. So it is more likely for the patient to require a cesarean section. Yes.
What about infections? Are there some infections that can dictate a cesarean section?
Yes, there are. One that comes to mind, actually two. One is the HIV, or human immunodeficiency virus, but that normally necessitates for planned or elective cesarean section. The other one will be the warts in the birth canal. This will be growths within the birth canal, which are prone to bleeding, especially during delivery, and that is the reason why we avoid as much as possible normal delivery in such patients and tend towards the cesarean section. Yes.
There's something called impending rupture of uterus.
Yes.
What is it?
That normally occurs in a woman who has had a previous cesarean section. So that means the uterus has been affected. That is common in it is a point of weakness because of the previous scar. So what happens is the mother may be in labor, complains of pain, and then the pain stops suddenly, or she reports possibly a gush of blood from the birth canal, or you may note that her vitals, or what you call the factors we look at, the blood pressure, the pulse rate, the mother's SpO2, or how she's taking in oxygen, are not what they were when she came in the possibly normal state. And that means impending means it is about to happen or already happening. Okay. So that is now an indication for emergency cesarean section to save the mother and to save the baby.
Because it is a big risk?
Yes.
Okay. Thank you very much. Now, you're here with the patient and you have prescribed cesarean section.
Yes.
Are there interventions that are done before the actual operation is done?
Yes.
Okay.
One of the first steps we do is informed consent. We have to inform the patient about what the operation is going to be about, why it is being done, and what is expected. So the next step we go to is rehydration. We talk about IV or intravenous rehydration, where we mention the drip stand, we connect fluids to the patient, and fluids begin to run. Something else that we do is the urethral catheterization, where a small tube is put along the path for urine, so that we are able to monitor what is going in versus what is coming out.
Because it's possible to have a lot getting in and little coming out.
Yes, it is.
For example?
In that case, we can think about what we had mentioned earlier, the CPD or cephalopelvic disproportion. The patient's the patient's baby may be compressing on the bladder. So at that point, the bladder is unable to evacuate the urine that she has. So that may be one of the indications for fluid being more going in than what is coming out. Another one would be possible urethral injury, but that again would be determined or discovered after the urethral catheterization.
Okay.
Yes.
What other interventions are done before?
Another thing that is done is taking blood samples from the patient to determine their, what we call the hemoglobin level, how much oxygen carrying capacity is in the blood, and to look at the kidney functions, if they will benefit or not react with the medications given in theater, and another sample to we call the grouping and cross-matching, which is to look for any available blood, if and when the patient will require, that it will be ready for the patient.
Because there are times when a patient needs blood.
Yes, during the operation.
Transfusion.
Yes, and sometimes even before the operation.
Okay.
Yes.
Are there any complications after cesarean section?
Yes, we can look at complications like immediately post-operatively, and that may be pain for the patient, which is normally sorted out through the pain control medications. Again, bleeding, which is another risk after the operation. And then we look at early post-operative complications, one of which would be infection.
Thank you. Shikilia hapo. Let's go for a break. When we come back, you'll tell us in details. Don't go. Thank you very much for joining us once again at Golden Minute Show as we fight against maternal, fetal, and neonatal mortality. In our discussion today, we still continue with emergency cesarean section. No, Daktari, we were at the point where we were discussing the complications. Can we pick from there?
Yes. So in the complications for emergency cesarean section, we can start with the immediate, one of them being pain. So that is controlled by giving the mother pain medication immediately after the operation, and it continues on for a duration of time, 2 to 3 days after the procedure. That is when the patient is in hospital.
Because the pain can extend that much?
Yes,
3
and
days?
even beyond the 3 days.
Okay.
Yes. Another complication in the immediate period, post-operative period, is bleeding. So in this case, we have to monitor the patient. That is monitored by what we call the pad count. A pad is put, and then the mother quantifies for the clinician over time how many pads have been changed, and if so, are they fully soaked, and we're able to monitor the output of bleeding after the operation.
No, you want to tell me after cesarean section, the blood will come through the birth canal?
Yes.
Not through the wound?
No, not through the wound.
Oh, okay.
Yes.
So,
not through the wound. So we monitor it that way, as I mentioned, through the pad count, and we actually it accordingly. So as we had mentioned earlier, as one of the preparation steps for the mother, the grouping and cross-matching sample. If the bleeding is persistent and excessive, we now make the decision to transfuse the mother at that point.
So that's why that cross-matching was very important?
Yes,
okay.
Because it carries on even after the procedure. Yes. And then other complications, now we think of the early post-operative period, that is after 24 hours. The pain may still be there, so we have acted on that with the pain medication. Something else is now infection, so the mother may tell you she's feeling fever, the hotness of body, or she's feeling the chills, or she may be having either the increased bleeding or discharge from the birth canal, which may have a foul smell. In that case, we suspect infection and we treat the patient accordingly. That is another potential complication for cesarean section. And then in the long term, alongside the pain and infection, there is something we call the chronic pelvic pain, which may occur following adhesion formation. After an operation is done, there is the risk of what we call bands forming in the patient's pelvis or abdomen after the procedure, and that may itself cause now chronic pain because it is compressing on the pelvic organs for that patient.
Okay, I've had mothers complain that huwa ninaumwa tangu nipasuliwe. In any case, they say tangu nichinjwe. Could this be the cause?
Yes, that could possibly be one of the causes. And so if a patient is having such complaints, it would be advisable for them to go to a health facility and be seen by a medical professional. So that may be ruled in or ruled out, and the patient is treated accordingly. Yes.
Okay. Now, after the mother has been operated on and discharged to the ward, is there any care, special care that will follow this mother that would maybe not necessary for a mother who delivered via the birth canal?
Yes. Alongside the mother looking after the baby, which has the issue of what had brought her to hospital, we look at the certain factors, the things that have changed for that mother, in particular, the wound for that patient. So there is the wound care. Part of it is the pain control. Part of it is the hygiene. The wound stays covered with a bandage or dressing for a certain amount of time, 2 to 3 days, after which it is examined. We also advise the patients on how to care for the wound in terms of keeping it clean, what medication to apply on it, and especially when they are, for example, coughing, sneezing, or laughing, we advise them to apply pressure, or slight pressure onto the wound to reduce the pain that they may experience, especially after the operation.
Okay.
Yes.
And any drugs other than the painkillers?
Yes, we also add on antibiotics, especially as we had mentioned, this is an emergency cesarean section. It was not planned for. So the patient may have had either an illness before the operation or may require them because of the need for, because of the indication for that operation. And we do prescribe antibiotics for those patients to continue even after the operation.
Thank you very much. Now that reminds me, there are times mothers have to be cut over here or over here.
Yes.
Are there any determinants?
I would say historically, the one we are calling straight down or the umbilical midline incision is a more classical incision. It was done faster because of, it was done previously because of, they said, easier access, and it was faster to reach the baby and extract the baby and deliver the baby. The one we have that we're calling straight across, or the fan and steel, is the more common technique used today. And it is used because it has what we call better cosmesis. It heals better, and the scar is not as visible as the one that goes straight up and down. Yes. Okay.
Now, as much as we are caring for this mother, we still care for the baby. Because, as you know, in our show, we fight against maternal and fetal and neonatal mortality. Now we have a neonate. At what point do you introduce the baby to the mother for breastfeeding?
Now, that will depend on what medication was used during the emergency cesarean section, depending on what we call the type of anesthesia used. If it was spinal, which is where it is a regional block, medication is introduced through the back and it numbs the patient. The baby may be introduced to the mother immediately. The procedure is completed, so she may start the breastfeeding. If the anesthesia was what we call the general anesthesia, where the patient has been put to sleep, we have to wait the amount of time that the medication will clear and the mother is fully awake before introducing the baby to the mother.
Now, thank you very much for bringing in an anesthesia, and our time is almost up. Does a patient have a choice over the anesthesia to be given, whether to sleep half or to sleep fully?
Yes, they have a right and a choice, but we advise them accordingly on a case-by-case basis, because each anesthesia has a use and an indication for it, and so we advise them accordingly depending on what they request and advise them whether or not it will be required or we can use another safer option. Yeah.
The last question, does it mean because a mother has been operated on, next time she has to be operated on?
No. If the mother has had only one previous operation and the indication for that previous operation does not happen again in the current pregnancy, she may or may not require the cesarean section. But if she has been operated on at least twice before, she will require an operation in the subsequent pregnancy.
So after this, she should be prepared that the next time may or may not be a cesarean section necessary.
Yes.
So, Dr. the main difference between emergency cesarean section and elective is that elective is prepared for. Am I right?
Yes, the elective is a cesarean section that has been planned for, but an emergency, it is immediately. But it has to happen then and then. That is what it makes it an emergency cesarean section.
Now, could you please tell me some advantages of giving birth normally? Now, we call it pushing, giving birth via the normal, via the birth canal over the cesarean section, whether it's emergency or elective.
One advantage for the normal delivery is that once the patient has experienced the pain and delivery is complete, the pain disappears. And now she has time to bond with her baby. But with cesarean section, there's a recovery time from the pain, from the operation, the medications that she's being given, and now the pain also from...
And you see the pain can go up to 3 days?
Or even beyond. So now that is pain she has to contend with.
I hope you have heard that.
After the operation. Another advantage for normal delivery is you're less likely to have bleeding in that patient compared to a patient who has had a Caesarean section. Yes.
And the infections?
Infections are also less likely to occur in normal delivery because, compared to Caesarean section, because in Caesarean section you have created another opening for the baby to come from. Yes.
Thank you very much. I've enjoyed the discussion.
Thank you very much.
Until we meet again, I remain your show host, Anne B. From us here in Golden Minutes Show, till we meet again, bye.